Thank you, Dr. Osorio.
Sorry, I know I'm muted. So let me just share one more time. Hold on, just because the way it worked the last time didn't work the way I wanted it to. Okay. So good morning or good afternoon. Sorry, it's been a crazy day already. So welcome for many. I think I've seen some of y'all's faces. Some I still have not met physically, and hopefully by the summer that will be different. Oh no, we actually had orientation, so I did get to meet you guys at least in June. So when we had our outside thing. Oh, so before I even started this slide, I normally ask if you know, we're talking about evidence-based medicine. I usually use like some website, but I realized that today I just said, let me just use the chatter, people can unmute. So we, you know, the topic is introduction to evidence-based medicine. So my first question is always going to be, you know, what is evidence-based medicine? When you guys get told like that we're talking about evidence-based medicine, like you can just use like 1 or 2 words, but just put it on the chat or you can unmute. Otherwise, I'll start picking on people. Go ahead. Nadeem, I see you unmuted.
Yes, I was going to say it's so trying to make medical decisions based on what we know from empirical data.
Okay. Anybody want to add to that? And you can chat if you don't have access to audio. One more volunteer. Evidence-based medicine, what does that mean to you?
So Emily, do you want to try?
I know. I feel like Nadeem just set the most perfect definition. I think it's also just making sure, I like honestly don't know if I have anything else to add.
No, you were doing great. So making sure of what?
That
I can add, Emily, I can help you out.
Oh, Bailey.
So I guess like just going off of what Nadeem said, it's just like also using clinical trials and like what works or not to guide how we treat / I don't know, give patients advice.
Yeah, you guys are doing well. And the hope is that at the end you feel more comfortable using the language. And then ARPON is medicine facts backed by trials or studies. So great. I think the only thing missing there is patient and clinical settings. So I think that's the only thing I would add. So everyone kind of used some of the terminology and really went into like what I was hoping that you guys would say. So really what we would say is evidence-based medicine is a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And the best evidence can really be, you know, expert opinion, or it could be a guideline that you're reading. And now we can even talk about non-reviewed websites that you can look at, some articles and studies that have not yet been published. And then you use that. So the practice of evidence-based medicine means that basically you're integrating this individual clinical expertise that you already have or are gaining with whatever is available externally in terms of clinical evidence from systematic research. So basically everything that you guys kind of put together with the idea that you're also, what impact is it having to your care of your patients and how you're making those decisions. And for, you know, this is a quote back from 2008, but I still use this, is it's for a 21st and at some point 22nd, but 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. And this could be the same that we might be saying about POCUS at one point, you know, doing your own POCUS or ultrasound, point of care ultrasound. And then last week we started having our EBM sessions for the 2nd and 3rd years. And the other thing that came up was just spending. And for many, you know, familiar with, you know, international, national in the United States, regionally, there's so many, differences in terms of costs and disparities of just even access and what insurance covers. But the thing that always comes up is, you know, healthcare costs and how healthcare costs has risen. And a lot of this could be even just the fact that we are in a nation where we don't have universal healthcare, and, you know, something like Medicaid, which is state funded. Most people understand that Medicare and the Veterans Hospital healthcare system, those are federally mandated, but also run by the federal government. Versus Medicaid, yes, the government provides money, but the state decides who is going to qualify and who doesn't. So I am from Texas. I grew up in Texas. Texas is a non-Medicaid expansion state. So most of the individuals that I treated in Houston were uninsured or underinsured, meaning that they didn't have Medicaid and their job didn't allow for any health benefits. And unless you had Medicare or a veteran system, you really didn't have the ability to access care. So just something that also comes up from a clinician perspective, this is something that we think about also when we're trying to advocate for our patients, and our patients are getting denied treatments because, again, the costs are other things. So we'll go into different examples, but the main thing that I hope to get from this hour is just really the introduction to the terminology and the study designs, and I'll try to make it as interactive as possible. So the first is just the vocabulary, and some of you guys who are already using this are aware of, and these are just kind of a snapshot of the different vocabulary that we're going to talk about. So this is familiar, systematic review, specificity, the NPV, which is negative predictive value, 95% confidence interval. So just kind of, we're going to start, this is an introduction with the hope that really your first year, you already have some basic stats concepts. And then the hope by your third year, you really are familiar, we talked about each of these different terms. And then a little bit the epi side of me, first you have to say, causal criteria, Hill's criteria. So what is the strength of the association that you're looking at? How consistent is it? How specific is it? Is there temporality? And for your medications or even intervention, is there a dose response? Is it a plausible conclusion that you're coming up with? Is there coherence? Is there experimental evidence? And is there an analogy to it? In terms of study types, there's different ones, and how we describe them are really observational versus experimental. So the first is descriptive, and that's your case report and series that majority have already completed. Or you have your analytical, which is RCTs, randomized controlled trials, cohort, case control, cross-sectional, ecological. And then you have your systematic reviews, meta-analysis, your expert reviews and practice guidelines, and then your cost effectiveness analysis that really have been more and more in the last decade been used. And I'm going to be keeping an eye on the chat. So again, interrupt at any time with any questions. This has to be given in any EBM session. So, this is our pyramid for EBM, and just really talks about just how the evidence is, the quality of the evidence and how the information is filtered. And we're going to go into each one. And I started giving these lectures, I think now 7 years ago. I still remember when we started with the first years, because in the beginning, the first years were not included in EBM. And giving this pyramid and just kind of talking about systematic reviews and how meta-analysis for me as a fellow, I was taught in quotes were trash. And I remember the intern who's now one of the attendees at one of the institutions in New York, kind of saying, what are you talking about? They're like the best. And I agree they are, but as a fellow in basic science, more, very heavy basic science, HIV, my mentor, one of my mentors, for meta-analysis, depending on the question that you're asking, and some of them are, basic science, it may not be the best. And so we were always told, don't present any meta-analysis, but we'll go into that and we can argue about that. But I understand in general, why this person said that. And I appreciate it. And I remember it. And I even said, who is this person? So she was one of our first years who went on to do cardiology. So another way to look at this is by exposures. And so you have an investigator, did they assign exposures? Yes. So that's an experimental study. And now you look at randomization. Was there allocation randomization? Yes. That's an RCT. If there was no randomization, so that's a non-randomized controlled trial. And then if the investigator did not assign exposures, now that's an observational study. So if there's no comparison, that's a descriptive study. If there is a comparison group, now that's an analytical study. And now you're looking at the direction of the exposure and the outcome. So if you first had an exposure and you're looking at outcomes, that's going to be your cohort. If you have an outcome that you're looking at, but now you want to see if there were exposures, that's your case control study. And then if you're looking at both exposure and outcome at the same time, that's a cross-sectional study. Okay, So it's all about the exposures and randomization versus not, and then if, when exposures were known. So first is a case series and case report. So, a case series collection of reports on the treatment of individual patients with the same condition or reports on a single patient. So now you're seeing, it's trying to show how people develop a condition over time and describing characteristics of these individuals. There is no control group, so there's really no statistical validity and no assessment of association, but they're very easy to understand and you can write them up in a very short period of time. This is just an example of patients and chart notes and kind of doing a case series or case report. A case control, the patients already have a condition, now you're comparing them with people who don't. And this usually you're going to hear odds ratios because you're using odds ratio to kind of see if the person developed the study condition or the estimate of what are the odds that the patient is going to develop the study condition or disease. And you can kind of look at associational relationship between the condition and the risk factor. They're not as reliable as RCTs or cohort studies, and you cannot really obtain absolute risk or incidence of a bad outcome. And then there's bias because depending on who you're selecting or the recall of the patients themselves, you may be introducing bias, and we'll go into examples about that in a little bit. But they're done quickly and they're very efficient, especially for diseases or conditions that are keyword rare. And then you have cohort studies. And for me, at the time that I was a resident, the Framingham Study was just being introduced. So I'm kind of dating myself. So it's still going to be an example. So the Framingham Study, for those who are familiar, it is a longitudinal study. So the main thing about a cohort study is that they are longitudinal. And you have this case-defined population that you really already have a specific exposure or receiving a particular treatment over time, and you're comparing them with another group. It can be done prospective or retrospective, and you usually are looking at relative risk, comparing the likelihood of an outcome with those exposed and unexposed. You can look at causation of the disease or evaluate the outcome or impact of a treatment, but you need a really large sample size. And a lot of reasons that you need a large sample size is because, the duration of time you may have lost to follow up. And so you really want to be able to keep whatever power that you're trying to obtain to make sure that you can even say anything about this exposure or outcome. They're not as reliable as RCTs just because the two groups may be different at different times. And so the keyword here is large sample size, basically because limited due to the long duration of time and mobility of individuals now, and maybe lost to follow up because of that. RCTs, most people are familiar with at this point, so randomized control studies. So you have two groups, a treatment group and a control group, and you're following them along, and you're basically looking at results for them. And they are still considered the gold standard for medical research. You're avoiding bias and you're allowing for comparison. And then a double blind is even further better in the sense that now both the staff and the patient don't know what treatment or therapy the patient is receiving. And this is when you see if it's a pill or an IV, like people are basically look very similar, so that both the staff who's giving the medication and the patient don't know what it is that they're getting, either the placebo or the treatment. It's most rigorous clinical research design because you're, again, still randomizing the subjects and you're basically risking or reducing the risk of bias for both the subject and the observer. And then you have the simple 2-arm parallel RCT, which you have your treatment and your placebo, and you're looking for disease or no disease or whatever outcome you're looking for. First, you start off with not a population, but a sample of the population, and you basically randomize them to treatment or placebo and kind of look at whatever outcomes you're looking at. And that's a simple 2-arm parallel RCT. Your crossover RCT is where, again, you have a population, you're looking at a sample, and the sample could be like people who have a specific disease or people who have specific comorbidities or even race, ethnicity, or gender or other demographics. And you look at placebo, you randomize them to placebo and treatment, but then you have this washout period. And then you kind of do treatment for those who receive placebo first, and then you do placebo for those who receive treatment. What this allows is that when you get them on the washout period, you're able to measure some outcomes here. So this allows you for data here And this allows for data here after washout. So both arms do receive the treatment, but at different times. And with this washout period allows you to kind of see outcomes. And so it allows also for you to have like an increased sample size too. And then the Factorial RCT is one of the even further a better RCT. And I guess this is where I pause because this is one that not a lot of people are familiar with. What's the difference with the Factorial RCT and then the simple 2-arm? Like, who wants to take that on? And I am known to call out on people, and I feel bad to call out on people who don't have their video on because it could be because of their audio, but just be prepared that you have to be there, okay? So
Don't feel bad.
We can take.
okay, so who wants to explain this?
So Adrian, do you want to help us out?
Jackie. Okay, I have to.
Hi, hi.
Go ahead, Adrian.
So you asked like Factorial RCT versus single arm?
Yes, so first describe this one, similar to what I did to the others. Like, what are you doing here?
So you're basically comparing two different treatments, or yeah, so like, yeah, two different treatments, like the drug A and B arm and then the drug A and placebo arm. Maybe.
Okay, and what's the difference between this versus this?
So that's like, I guess 4 different variables maybe versus the other one.
So what's going on here? What's going on with this arm?
So you're giving both drugs in that arm.
Okay, and then this arm,
Drug A and placebo.
and then here,
A different placebo and a different drug.
okay, and then here.
2 placebos.
Okay, very good. And then someone else, so what does this allow versus this one? What does it allow you to do?
I don't know, like, but I guess it gives you more combinations to understand like the nuances and the effect of different drugs, either in combination with each other or alone. So you can like understand, 1, does either have an effect? 2, what is their effect alone? And 3, do they like maybe have a synergistic effect, or what is their effect in combination?
So very good, because you used the word synergy. So here, drug A and B, you're combining them, right? So you're kind of seeing, is there like an augmented synergetic effect from having both together? Here, you're only looking at drug A alone because B drug is placebo. Here, you're looking at drug A alone, sorry, because you're giving the B placebo. And then here, you're looking at drug B alone with placebo A. And then here, it's all placebo. So here is your all placebo. Here, you're looking only at drug B. Here, you're looking at drug A. And this allows you to see if there's a synergy effect from giving both drugs. And then now you're looking at your outcomes that you designed from the very beginning. Why don't you think that most studies are done this way versus this way, where one arm is just giving a treatment and a placebo? What is it that is a limited factor? And Demi, Raj, you can probably answer this. What's the limited factor with doing it this way? I mean, this would be a great ability to do this, but what's usually the limitation?
Yeah, well, Gleed in the chat said money. I would say getting a good sample size to do this much testing.
Khalid, I like your money answer because that's correct too. But yes, sample size, right? Because the problem with this is you really are not having 4 arms, and you really need to make sure that you have enough sample in each of these arms, because you don't want this outcome to really not be significant because you're underpowered. And so that's one of the, first is the sample, like making sure you have the prevalence of whatever you're looking at, or, comorbidities, demographic factors. And then it's, okay, now can I put them in 4 arms so that I actually have enough sample here at the end, because you're attributing, you have to account for, attrition rate, are people going to be lost to follow-up? Are people not going to want to continue on the study? Are people unfortunately going to pass away? So those types of things. And so you want to make sure you have the ability to say anything about what your outcomes are at the end, your results. And so that's why this is one of the best studies to look at. It's just the limitation it's going to come down to is really the sample. And yes, money. Money is always going to be an answer for many of these studies. And then the end, so very good job. You guys know what you're doing. So N of 1 trial is just a different one where now you're looking at a patient and they're undergoing pairs of treatment periods organized by one period, basically involving an experimental treatment, the other one where they're just getting placebo alternated therapy. And usually the patient and physician went blinded. So you kind of see what's going on here where they're getting drug versus placebo and drug and placebo again. So that's an N of 1 trial. Then meta-analysis, everyone's familiar with. So it's just a systematic, objective way to basically combine all the data from the studies. And usually they're the RCTs that you're combining, and allows for basically a pooled estimate of what, is the effectiveness of this treatment that you're looking at. It does, allow you to increase your sample size, and maybe you have these analyses that you maybe couldn't do because the samples would have been too small. But the limitations, is publication bias and the quality of the design of the study in which the data is pooled. So who wants to take on? So Sarah, what is publication bias?
Not really sure. I don't know.
Who wants to be the lifesaver? Darren. I see your eyes. I don't see everything. So I know you're there. So Darren.
Basically they're saying that like you're less likely to publish negative results, and you're more likely to publish like positive results and so you're by increasing the number of studies, you're decreasing the likelihood that that's going to happen.
That's true. And I think most people do think, I think it's a component, and it's a larger component is that because it's who are the ones publishing? They're the journals, right? And now we can talk about, MedRx, right? This unpeer-reviewed access to these studies that have not been peer-reviewed, but you can look at the results of the studies, that it was very popular during COVID time and now is like known. So those haven't been vetted or even published in the journal, right? So first you have to be like, okay, who is actually deciding who, what articles are being published? So first are those journals only wanting things that would show positive results? So is that the publication bias? Or is it also that's the same people that are always publishing regarding the same clinical question that you're looking at? So some of it is a combination of things. Some of it is that, yes, more willing to publish positive results, journals. And then the idea that, who are the same people that are being seen, and is it the same in the same population? So that's just, something. So bias is just being introduced by, who are the people who are being published versus a systematic review. Gray literature, Nadine, great. So systematic review, now you're looking at both published and unpublished. And you are even looking at even abstracts at meetings. So, ATS, the American Society of Hematology. So a little bit more unbiased. And now it's more of a qualitative view of the studies. And, this is when people I think both people can reach out to authors and just get more information about the studies. I always encourage people to email the first authors. I did that all my training. Even with this, vaccine Moderna, I was emailing the first author of the Moderna original study, and they will respond, and they actually appreciate you, asking questions and things like that. And it's okay. It's not it seems like a big deal to email some of these first authors, but actually that's how you start networking and kind of, getting to meet people in different institutions. And I've done that all my career. And yes, email was just starting at the time that I started. So just joking, trying to keep y'all awake. Okay, so for the meta-analysis heterogeneity, so this is where you talk about Higgins. So what is the variation between the different samples that you're looking at? And usually here for heterogeneity, the highest, you have low, moderate, and high. And high could be anything above 75, but here are, significant is above 50. So when you're doing a meta-analysis, do you want a lot of heterogeneity or do you want a low heterogeneity? Arpan. You're muted.
Okay, I'm sorry about that. Yeah, I think
Oh.
I would say it would be low heterogeneity, so we can say that results are like more consistent. If the curve is too wide, we can't be sure.
What do you mean by that? So that we can say that the results are more consistent. What does that?
I would say, so if we are looking on a meta-analysis of a drug to look for, so say we have like 10 studies and we did a meta-analysis, and if it's too heterogeneous, it would say that the drug would have different effects on different like maybe it works in some condition, it doesn't work in others.
Okay, because the conditions are the thing that you're talking about, like what was done in the actual study design for that study, that specific one study versus the others, and then the demographics. So what you're looking at, you don't want too much differences in just how the studies were done and conducted and what were the measures of effect that they were looking at. And you also don't want much difference also even in the sample. Anyone else want to clarify, heterogeneity? I don't want to, Jonas.
Yeah, I mean, I agree. This value looks at how heterogeneous the studies are in terms of their patient population, in terms of their age groups, for example, or ethnicity they're looking at. That's what I understand under heterogeneity.
No, so very good. So here's an example. And so these are the different studies. And so here the heterogeneity, depending on the intervention, the group, and then all these different studies that were conducted is usually listed here. So diversity between the studies, basically. Okay, I'm trying to keep an eye on the time too. Just an introduction on the phase trial. So clinicaltrials.gov is another website that I always kind of tell people to look into when you're trying to design a study. It's really nice. Every NIH funded, federal funded basically study needs to register themselves here, and patients actually even look at this to see what studies are going in the area. And phase 0 is just exploratory, and now this is very limited human exposure. You're just really not looking at therapeutic or diagnostic goals, but looking more at like microdosing and dosing of the drug that you're looking at. Versus phase 1, now you have healthy volunteers, and now you're looking more at safety and adverse events of this medication that you're looking at, and then just how it's metabolized. And here you usually start with a small group of people. And then phase 2 is a larger sample size, but now you're looking more so at effectiveness of the drug. And you're trying to compare the participants receiving the drug with those receiving a different treatment or a placebo. And safety continues to be evaluated, and you keep on looking for adverse events. And then phase 3, again, you're increasing the sample, and now you're looking more at safety effectiveness between different patient populations, different dosages, and also drugs in combination with other drugs. And by phase 4, most studies at that point have received approval from the FDA, and now you're looking more at drug safety, efficacy, and just optimal use. And so just be familiar with these terms and what 1, 2, and 3, and 4 trials include. Now the concept of per protocol versus intention to treat. So who wants to take this on? So this is patients with CVA, and they're being randomized to surgery with aspirin or just aspirin alone. And who wants to take, what's the difference between per protocol and intention to treat? So now I'm going to ask the people who do not have their, this is a hard one, Jay. Who wants to take per protocol or intention to treat?
I can try. So per protocol, I would include for the final analysis only patients that followed all the study protocols. And then I would exclude patients that for any reason stopped to taking the medication or anything like this. Then for intention to treat, I would sort of simulate a real life scenario in which I would randomize the patients. And then even if they stop taking the drug for any reason, they will still be included on the final analysis.
So can you use this example to do exactly what you just said right now? What's the difference between per protocol and intention to treat?
So for the first, so on the top, out of the 90 patients that were initially randomized from what I got.
So you have
So-
100 that were randomized to surgery and aspirin, 100 that were randomized to aspirin alone. What's the difference with these numbers, the pro protocol and intention to treat? Exactly what you just said, but use this example.
Yeah, okay, so on the per protocol analysis, for the final analysis, I removed all the patients that did not follow the protocol. So for example, the number that I have on the lower denominator, it's only 90. As in comparison with the intention to treat analysis, I did not remove any patients. I kept all of them, even if they do not follow the protocol. So I still have 100 over here.
And what happened to these 10? What is so here so what's here? Surgery, right? So they had this surgery. And so these 10 people left before the surgery was done. So what happened now? So now these 10 left, right? So they didn't get this. And so they weren't included here, and that's why it's 90. So it's exactly what you're saying. I just want people to be able to understand it for those who more of a real example. So here, what Bruno just said is that, these were the 90 here. You didn't include the people that did not go, because they left before the surgery, versus here you did include that. And, someone, Bruno already mentioned, which one's more realistic or real world, and what people kind of think about, pro protocol versus intention to treat. And that's what I just want you to gather from this is, intention to treat is the comparison of the treatment groups that includes all the patients that were originally allocated after randomization. So you keep the randomization, you avoid the overestimation of the treatment effect. Versus pro protocol is a comparison of treatment groups that includes only those patients who completed the treatment that originally allocated. So here, these individuals didn't complete the treatment because they left because they had stroke and they didn't get the surgery. And, there is a large loss to follow that can introduce bias. And so most people kind of, feel like, I like studies, and many of you guys may have heard this, but to this day, I say I like studies that include both analysis in the end, but a pro protocol and intention to treat, because it allows you to kind of see what would happen in a generalizable population like our patients in the clinic, like what would happen if they weren't able to complete the study for different reasons. And most studies now do include both, but before they used to just do like intention to treat or pro protocol depending on the study. So just, again, I just want to introduce you. I know I don't want to overwhelm everybody. So then what we do is we do use the JAMA guidelines to do more of the critical appraisal of our guidelines, so of our articles. So the different ones that we focus on are going to be therapy, diagnosis, prognosis, and harm over time in the next, 3 years. The therapy most people are familiar with, and the reason I structured EBM this way like years ago was just that most of the articles that were being presented were therapy, and we weren't being introduced to other types of study designs. So therapy, most people are familiar about, what is going on with treatments and the outcomes when people get put on treatment. So how does treatment change the course? And most of these are RCTs or double blind. Then diagnosis, you're looking at a test, like a diagnostic test and sensitivity, and basically, is asking, are you able to identify a disorder in a patient presenting with specific symptoms using this test? How do we make the diagnosis? How accurate are the diagnostic tests? And these are usually also controlled trials. Prognosis is looking at over time, the course of this disease, what's going on in terms of complications and progression, or the likelihood of a disease, what is the outcome, what factors are associated with poor outcome. And so these are usually cohort or case control case series. And then the harm is just, when you're looking at diseases and what's causing a disease, what are the contributing factors of the disease and what could be a negative impact from an intervention or other exposure. So, usually these are cohort studies. And, one, example I have here, and this is a very simple example, is what is the evidence that attending lecture is beneficial at IT or having your video on when you're on didactics? So the null hypothesis is you're going to say no association between lecture attendance, the exposure, and doing well on the IT. This will be, the exposure will be documented by a self-reported answer to a question. How many core lectures did you go to in person at that time? during a review session. So there's a review session, people are being asked how many core lectures did you go to, a self-reported. It's being dichotomous, like you're gonna dichotomous these answers where 0 is none or some, because you're gonna just use a dichotomous variable. Or you're gonna say all, meaning that they went to all of them or most of them. Now you can question even the way the person designed the study and created the variables. So then the outcome would be, what was your ITE score? And looking into it, also, if did you fail, with 0 would be less than 70% you failed the ITE, or you passed. And this is a makeup example, okay? Don't read into any of this because that's not the definition. Or you pass, 1 is that you pass, meaning it's more than 70%. So you're collecting the data, you only get 20 people that failed the ITE, and of those 20 that failed the ITE, only 10 attended this review session where you asked how many lectures did you go. So 50% of those that failed in your whole class were able to tell you how many lectures they went to. And you find that 6 out of 10 of those said that they didn't go, that you put them in the none group, like they didn't go to any of the lectures or very few. So then you do your 2x2 table, and your outcome's going to be that they passed the ITE, passed or fell, or they didn't, and they went to all, the exposure was that they went to all the lectures or they went to none of the lectures. And when you put the numbers, then I think oh, here you go. So then when you put the numbers, very simple, you know, it's 8 went, you know, past the ITE and went to all the lectures, and you see the rest of the examples. And so what you find is you're able to calculate the odds ratio with that. And with that odds ratio, you find that there's a 6 odds. And what does that mean? It means that people who passed the ITE were 6 times more likely to have attended lectures compared to those who have failed. But what happens with that is you're introducing bias, right? Because what I told you is that, you know, we are only getting the people who went to the review session. You're not looking at the whole class. You only were able to ask the people who were in the review session. So you already introduced bias by having only that question asked by those who went to this review session. And so you don't really know of these 10 people who passed the ITE and attended a review session, are they really representative of all the people who passed even? And then you have recall bias. The recall bias gets introduced because it's all self-recall. Like you're asking these individuals, they don't remember. Maybe they're gonna guess like how many lectures they went to. And then it's a small study so that your very, you know, your confidence interval becomes wider. So now you start doing a cohort study, and now I want to look at all 100 of you who enrolled in this course. And you're going to look at, you know, 70% who we documented that you attended these lectures. And now you see that 65 people reported all lectures and they passed the exam, and 5 failed, but they said that they passed the exam. And then you see the other numbers here, and you calculate the relative risk. And here you find that your relative risk is 1.86. And now you say that those who attended lectures were 1.86 times more likely to pass the ITE than those who did not attend the lecture. There was no selection bias because everyone was sampled, and there's no recall bias because everything was documented. And your confidence interval you see is smaller because the sample is larger, and then it's more precise, like what measurement or that effect that you're trying to find. But let's say that you find actually a bad outcome, meaning that you find that 0.94, like, oh my God, what happened here? Because now you're saying that those who attended lectures, because we changed the numbers around, are less, like those who attended lectures were 0.94 times less likely to pass the ITE and then those who did not attend the lecture. Now you're gonna be like, oh my God. And this is what we always come up with when we come up with a question, we're saying, oh, this is significant. You have to look at what's going on here, because what are the confounders? The confounders could be that maybe those who didn't attend a lecture, they already have some proficiency in the lesson that's being taught. Or maybe now, like for especially those who are med ed, you know, people learn differently. Maybe they're not the people that want to be attending a lecture and they're reading books or doing podcasts or videos. So are they doing their own learning? And that's not something you're going to capture. And so you have to account for these confounders whenever you look at a study, is the main thing. So that's just like a simple example. So further on terminology. So internal versus external validity. So internal is, you know, experiments are usually high in this. This is like your bench research. versus external validity. These are usually like observational RCT. And what you're looking for is really like generalizability of the study. And so one picture I used, this is an RCT. So your lab experience is very high in internal validity, but very low in external validity. And then your observational study is more generalizable. And so it's going to be higher in external validity. Reliability and validity. So reliability is about being consistent, stable, dependable, the measure that you're looking at or the result that you're looking at. So here, this is very reliable, but not valid because it's not going into the target. Here you have very low validity, low reliability. Here it's not reliable or valid. And then here you have both reliable and valid, okay? What is alpha? So alpha is just basically the probability of rejecting the null hypothesis in favor of the alternative. And this is where you hear type 1 error. So it's arbitrary set at 0.05. And so this is basically your false positive or the benefit that is perceived when really there is none. So false positive is another way of you thinking of alpha and type 1 error. And then for beta, this is the probability of failing to reject the null hypothesis when in fact this is false and a true difference actually exists. So this will be your type 2 error that's usually set at 0.2 or 0.1. And the benefit is missed because the study has small numbers could be another way of looking at. So this could be your false negative is your beta or your type 2 error. Now some of these people are familiar, but for others it might be an introduction. And then probability is just your 1 minus power or beta, sorry. And I have here, like, what are things, and I'm just because of the time I'm looking at it, what are things that affect power? So sample could, affect power, the magnitude of the difference of the effect size that you're looking at, the outcome of those in the unexposed, or even the type of the measurement that you're using. So those are things that we want to kind of look at. And then just what determines sample size. And the main thing is, very quickly, why do you think that maybe a cardiology article sometimes, most of the times, just going to say, oh, this was 80% power, versus a hematology oncology article might say, oh, this was 90% power? Why do you think that exists in different fields? Like, why are we okay with cardiology saying 80% and not 90% versus hemonc, we're okay with them saying 90%? What's the difference between those two fields? What's going on? How prevalent is hypertension versus how prevalent is what polycythemia vera?
Yeah, so they use, you need to be more stringent when it's a common effect. So like in physics, they use like tiny p-values because things happen all the time.
But there's a high prevalence of what you're looking for, right? So because you're going to be able to obtain that sample very large, your power, you may have to be a little bit more like, let's like at least try to get 90% power, like versus cardiology will never get away with saying, sorry for cardiology, but I'm not trying to pick on y'all, get away with saying 90%, because if that happens, everyone's going to be like, why are you using 90% power versus 80% power? So you'll look at that. When you look at a study, you'll start seeing 80 versus 90 and question, why are they using that power? And are they able to say that? And then confidence intervals, the main thing to look at is just, it's the range that we expect with some level of confidence to include the true value of a population parameter, such as the mean or true treatment effect, okay? And it gives us an idea of like this parameter that we're looking at, how precise are we in terms of this measure of effect that we're trying to look at. Diagnostic test, this is the 4x4 that most of you guys are familiar. And just introducing, for many, the sensitivity versus specificity. So sensitivity, looking more at, defined as the proportion of positive results in a patient with a disease out of patients with the disease. And then specificity you have here and spin and snout. And I'm just going to kind of go over very quickly. Positive predictive value is how predictive is the positive test result versus negative predictive value is how predictive is a negative test result. So I have this example. And if I tell you that ACAS, AMI, see chest pain here, that was a positive diagnosis, and non-ischemic and definitive other diagnosis was a negative diagnosis. And then you have stress tests, you have abnormal, none, and normal. because of time. So likelihood ratio, this is when we're going to talk about more diagnostic testing, so pre versus post-test probabilities. And you're looking at sensitivity, specificity, and these likelihood ratios. And really what you're trying to say is, you know, positive is that the likelihood ratio of this test in your diagnosis is correct afterwards, will be likelihood ratio positive, and then likelihood ratio negative you're seeing here. Likelihood ratio is more independent of prevalence versus predictive values is going to be more dependent on the prevalence of the disease in the population tested. So what you see here, and I put an example of an ultrasound for DVT because that's usually the example that always gets used. So if your pretest probability is very high that this is a DVT, and you do a test and that likelihood ratio is 20, so you go up here, you see that your post-test probability of that diagnosis by using that test goes high. So now you're more confident that your diagnosis is correct by doing this test. Okay, so that's pre-post-test probability and where likelihood ratio kind of goes into play. And we'll talk about that as we talk about diagnostic tests. So because I promised that would be on time, kind of skipped over slides. So what we're going to do is we kind of reformatted for those who were able to attend the IME, and for those we try to reformat EBM a little bit more, because we want you to focus on the clinical question that's being asked in the study, do some critical appraisal, and do the PICO format where you're going to be asking, what is the patient, what is the intervention, what's the comparison arm, what's the outcome, and then these two T's get added, you know, what's the type of question, what's the type of article. So an example here, in patients with class 4 CHF, and sorry, this is old for the cardiologist, I know it's HFrEF and things like that now, does treatment with a beta blocker prevent diagnosis as compared with placebo? So here the patients are, you know, people with class 4 CHF. The intervention is a beta blocker. The comparison is those that receive placebo. And the outcome is you're looking for death. So that's the PICO format for those who may not be familiar. So after we have this article, that's a rigorous scientific journal, you then want to do the critical appraisal. We'll have like the JAMA guidelines for these different types of questions, therapy, diagnosis, and harm. But what we're going to hope by the end of your first year is that you've gotten introduced to basically these terminology. So for therapy, we'll focus on what is intention to treat per protocol and how to do number needed to treat. For diagnosis, well, that's what we'll introduce, like likelihood ratio and positive and negative predictive value. And for harm is when we'll talk more about relative risk and odds ratios, so that when you're a second and third year, we'll add more information and kind of build on that and really be more nitty gritty on more of the statistical analysis of the study, because what we're trying to do in the 3 years is grab everybody, not, you know, I have a group of people that have lots of, you know, background versus have a group that don't have any background, but I have also people who are very eager to learn stats, and then others who maybe not as eager, but understanding that myself as a clinician, understanding that any insurance now is going to be looking at guidelines and articles to say, no, we're not going to cover your drug. Yes, we're going to cover your drug for your patient. My example that's classically I've used for more than 5 years is when the new drugs for Hep C were coming out. My patient had failed the first inhibitors that were developed, and he was co-infected HIV Hep C. I was trying to get him Harvoni, which now seems like very old. And the insurance denied it because they said, oh, this hasn't been studied in individuals who have failed therapy before, like interferon and the other drug. And I Googled, or not Google, I put PubMed is my thing, is equivalent to Google. I PubMeded and I found it was like a phase 2, phase 3 study of a very small sample size, only Hep C mono-infected who had been treated with Harvoni, who had failed previous treatment, who basically cleared the Hep C. And now that seems old because that's proven multiple times now. And I used that small study to basically get my patient this medication. Now you can say as the doctor, the clinician, and the researcher and the one that can critically appraise that say, oh, but it was only 20 patients. Oh, but your patient was HIV Hep C, not mono-infected like this study was. we know this, but the insurance doesn't. So I was able to get it that way. So just know that this is how you advocate for your patient, and it's useful for all of us to kind of know why some drugs are covered, why not, and when at some point should you advocate for your patient to get this medication. And patients are coming with articles and telling you, oh, why should I be on aspirin or not, especially with this whole regarding cardiovascular risk, and how relevant is this article to me, my patient, me, myself as my demographic or not? And you explain it to them by looking at the figures. And with that, because it's exactly 3:56, but I'm 6 minutes behind, is I leave it with that. And if you have any questions, because I know I want you guys to get a break.